welcome to episode number 3 of STA Clinic Chat. This one is Introduction to Principles of Rehab. This is our new clinical reasoning education series. So throughout this, we will be referring back to some of the stuff we discussed in the other chats. If you haven't been on the other chats, don't worry, because we will discuss some of the stuff throughout. If any of you do have any questions, stick your hand up in the chat or give me a wave on camera. So, right, what we're going to be talking about. So, introduction to rehab. So, what is rehab? So, I thought I'd kind of go through a couple of kind of definitions, really, and quick overview of what you should expect. So, some of this is probably quite old hash to some of you guys who've been doing rehab and treatment for a fair while. So the rehab plan, 2 seconds, I'm going to mute. The rehab plan must take into account the fact that the objective of the patient, I'm going to kind of flip between patient, client, athlete for the purpose of this, because we have very different backgrounds, is to return to the same activity and environment in which the injury occurred. Functional capacity after rehabilitation should be the same, if not better, than prior to the injury. I say that with a pinch of salt, because if we have a layperson who decided they were going to go to the skiing for the first time ever and they became injured and they don't plan on ever going skiing, obviously we have very different kind of backgrounds with that. So they're not probably going to be going back to that thing. But if we have footballer, rugby, runner who wants to get back to their sport, that is very pertinent. The ultimate goal of the rehabilitation process is to limit the extent of the injury, reduce or reverse the impairment and functional loss, and prevent, correct, or eliminate altogether the disability. That's a kind of quick overview of a couple of aims of what we expect from a rehab. Very wordy. So, because this is a clinical reasoning session, we want to kind of go back to the first 2 sessions, which were on introduction to assessment, and that was subjective and objective assessment. We are going to be going more in depth on different joints, different injuries as we work through this series. And the second episode was on neurological assessment, so it was introduction to kind of how we do that. Everything we're going to talk about in this session relates back to that, because we're not just getting people to do exercise for the sake of doing exercise. It has to be for a reason. So the first thing you do before, or the first thing I do before we do any planning or rehabilitation, is go back to your assessment findings. So what was the mechanism of injury? Sometimes that is very important from a psychological and physiological standpoint. Sin factor. Some people will have come across sin factor. If you've heard the previous sessions, you'll have understood what sin factor is. So it's severity, irritability, and nature. So the severity, how symptomatic it is. Irritability, how much they can do before the symptoms increase. And the nature tends to talk about where the actual symptoms are coming from, what kind of tissues. One of the biggest bits for me, patient and athlete goals and motivations. I don't think you can really plan a proper rehab session or treatment plan, anything to do in our thing, without knowing what that athlete, what that client in front of you wants to get out of it. You'll have your ideas about what you want to do. You'll have your clinical ideas, but it needs to amalgamate and it needs to fit together like a jigsaw puzzle with what their motives are. Any hindrances or obstacles that may come in your way, you will find that out from subjective assessment, hopefully. When I talk about hindrances, it's family, it's life, it's work, it's money, it's those kind of things. Motivation, general fitness, these kind of things. These are all the things that we need to consider when putting in plan for a rehab kind of progression. Because ideally, this rehab plan isn't going to be, right, here's a couple of exercises, go away. The idea is that we kind of start from the beginning, whatever your starting point is, and we plan to the end Okay, so that's what we want from our subjective, our objective. So what tissues are involved? I think that's quite important. What joints and movements are involved? The active range of motion, passive range of motions. What's the quantity? What's the quality of the movement like? Strength and control. So they might be really strong, but can they control that? Can they do it in standing? So if they've got knee extension, that's fine. If they're in seated and you're doing an isometric knee extension, but if you get them to stand up and do a squat, can they control it? Is it that kind of thing? Are the symptoms local or are they global? When I talk global, you get your people with chronic pain. We've all had those in clinic, like where it's like, right, well, actually, it's my back, but it's this, and I've got this, and they've got a multitude of things. Sometimes you need to take it back to the source of what you think their priorities are. I refer back to the introduction to assessment, and I prioritize and I list them as number 1, 2, 3, however many, and we kind of work through plan that way. So going through those different kind of symptoms and what their priorities are will help you in your planning stage for this. Excuse me. So what tissues are affected and how does this affect your decision making? We all know what tissues of the bodies are. We haven't got this far in clinic without knowing what these are, I suppose. But they do obviously react very differently to injury. They get injured in different ways. How we load, rehab, treat, all will differ quite a lot. So you're not going to treat a ligament injury the same as you would a bone injury. So if they have a fracture, the rehab, don't get me wrong, the end rehab will probably start to look quite similar, but in the beginning stages, it's going to look very different. What stage of healing, or what stage is the injury actually at? This is quite an important part for you, because you need to know what your starting point is. So quick overview of like healing. I'm not going to go massively into like healing processes and all the kind of physiology behind all that, because that's an entire series just on itself. There's a general rule of thumb from literature. The acute stage post-injury between 1 and 7 days-ish. I tend to kind of go to kind of 1 to 3 to 4 days, depending on how severe the injury is. Subacute stage is 3 days to 3 weeks. Very ballpark figures because it depends on severity of the injuries. And the remodeling process, 1 to 6 weeks. Is this a chronic injury? Is it an ongoing injury? Is it an acute or subacute kind of injury? How severe is that injury? When I'm talking severe, is it, we go to the graphic on what is on the right-hand side of my screen. So muscle strain, is it a grade 1, grade 2, grade 3? Ligament sprain, is it grade 1, grade 2, grade 3? These kind of things. So that's what we need to know, because we need to know or have a good idea at the level. If it's a muscle injury and it's a grade, like high grade 2, fair bit of tear in there, there's going to be a lot of bleeding, there's going to be a lot of swelling, there's going to be a lot of pain, there's going to be a lot of weakness, there's going to be pain with movement and everything. The way your starting point with that varies massively, as if it's a grade 1 with very little kind of fiber damage. From a healing point of view, that is going to be very, very different starting point. So with a grade 2 quad strain, let's stick with that. Do we want to get them doing high level strength stuff at the beginning? Because everybody loves a little bit of strength and conditioning in rehab. Is that appropriate? So that is one of the major things about the planning side of it. Be safe and effective. Don't start doing things just because it looks good on camera or because it makes you look impressive. We need to get these people back the most safe and effective way possible. And that's where the planning bit comes into it. Okay, so once we've got an idea of what our starting point is, we can move on to kind of the actual planning side of it. And I always say treatment and rehab starts with the immediate care. If you are there, if you are doing pitch side stuff and you are there, the treatment starts as soon as you get them off the pitch and you start to do your stuff. There's a graphic on the screen there. When I was training, and as most people have heard of, is price. So protection, rest, ice, compression, elevation. Literature's kind of moved away from the ice kind of side of it. I'd say it's moved away. Rest, I've always thought, is a little bit of a dangerous term with regards to telling people to rest, because it's how much do you rest. You tell somebody to rest, they'll just go lay down on a sofa and do nothing. I always call it active rest. So it's, yes, you need to kind of move yourself away from things that are probably going to cause you increased symptoms, but don't stop. You need to keep moving within your tolerance range as much as possible. So the stuff now tends to go around peace and love kind of side. So this is a graphic taken from the running clinic. I think this has been reproduced across social media and literature quite a bit. I did try to find the original one, but I couldn't find it. I think it was behind a paywall. So this stands for protection, and that is avoid activities that cause increase in pain. So it's not saying stop, it's not saying rest. Elevation, that's to aid the swelling. Avoid anti-inflammatories, that includes icing. I remember having an interesting discussion with a lecturer quite a few years ago. Our bodies, my kind of thought process was, our bodies have evolved over millions of years, and this inflammatory process has evolved for a reason. Why do we want to stop that in the immediate stages? Surely if we stop that initial inflammatory stage, we are delaying the onset of the healing process. The stuff that comes to an injury site in that initial stage is important to kickstart the actual healing process. So literature now, and we stick with this for the purpose of this talk, avoid anti-inflammatories. Compression, that will aid in reducing swelling. And that's like excess swelling that may be present around a joint, around a muscle. Education, so tell them what they can do, what they can't do, what is appropriate for them, what is not. Load, so we start on the love bit, so L is for load. Literature and research now, which we'll get into later on, early loading is really, really important for decreasing time away from play or time away from game, training, this kind of thing. You lose your fitness in this kind of situation very, very quickly. So the quicker you start loading tissues and loading joints safely, the better. Optimization. So optimal recovery by being confident. So this is where the psychosocial side of it starts to come into it a little bit. So if somebody is a little bit down about injury, which happens, if somebody is torn an ACL, they know they are in for a long road. So this is where we need to kind of keep them positive. You know, there is light at the end of the tunnel. There's still stuff we can do with them. You know, keep them involved. It's just obviously we can't load that knee. Vascularization. So getting the blood pumping around the body, that will help aid the healing process, take good kind of nutrients and aid the physiological side of the healing process, as well as help reduce and remove anything that is not optimal. And exercise, and this is where the rest of it comes in. So rehab plan, the amount of times I've seen rehab plans, and it focuses on a knee for a knee injury, and it completely disregards fitness element and the exercise element that they need to actually play their sport. So if they're out for 6 weeks and all they've been doing is knee exercises, they're going to be an absolute mile away when it actually comes to getting back to their sport. Any questions or any comments on this peace and love thing? I'm going to take that as a no. Okay, so rehab and training. Rehab is training. It's exactly the same principle. It has just got a different starting point. So if we're working with athletic populations, generally they will be part of some sort of training program. They will be at one end of the scale, pre-injury. When they get injured, they just move back to a lower level. But the same principles that you use in a progressive overload training program apply to rehab, because it's the same thing. So generally, aims of a rehab program: decrease pain and swelling in the initial instance, start to or increase strength, increase motor control, increase resilience. So when I talk about resilience, we're talking about reducing further risk of injury. Progressive overload, so we don't just kind of go, here's a load of weight. If they're used to doing a 3 RM back squat, if they're injured, we are not going to get them doing a 3 RM back squat, because their 3 RM now is going to look very, very different to what it did pre-injury. And what we look for when we're training the injured site is to do with the SAID principle, which is specific adaptations to imposed demands. So you only kind of get out, the results you get are only what results of what you actually put in. So the resultant of the stimulus you actually give it. So if all you give him is a really light yellow TheraBand to do some knee extensions with, and it's 3 sets of 10 of that, and then all of a sudden you go, right, we're going to start doing some, body weight squats, like body weight on the bar. The adaptations are not going to be there because it will not have adapted. It'll have only adapted to the stimulus you provided. So it's about progressive overload and adapting to the actual overload and the adaptations imposed on it. Any questions on that? Yeah. So I thought I'd throw this bit in to follow on from that. So this was Ebony Rio. So this is a graphic taken from one of their papers. And it's a nice little graphic to kind of show where strength and motor control come in regards to injury. So if you look at strength, you have strength and motor control. Insufficient strength and insufficient motor control for the task at hand. So I'm going to use rugby as an example. So I've got a winger who needs to catch the ball and needs to sprint and be hit. He needs to be able to push people away. If he hasn't got the strength to be able to kind of cope with the physicality of it, and he hasn't got the motor control to catch, land, and take off, and that's the demands of the sport, it is going to result in an injury. Some people may have strength, so they may batter the gym, they may be really, really strong, their deadlift, their squat, their bench press may be superb. But if they can't control that strength in a game situation that has unpredictable outcomes, they are still at a risk of getting injured. And we move to C, where they aren't very strong, but they have good control, they have good coordination. So they're nimble, they're agile, but they're not very strong. Eventually, that is going to probably result in an increased risk of injury. I'm not saying everybody will get injured. So in an ideal world, for people in a sporting situation, and this relates back to people that we see from general population as well, we need strength and motor control to be able to perform the task at hand. So this, if we relate this back to clinic, this is Doreen, who's 70, who has decided to go shopping, and instead of getting the bus back, she's going to walk back from the shops 2 heavy bags of shopping. She's got to cross roads, she's got to go upstairs, she's got to go down things, and she's got to hold these bags out. If she's never done that before, and she doesn't have the strength in her arms and in her back and in her legs to carry that shopping and to get up and down and navigate the paths, it's probably going to result in aches, pains, and niggles. And that's where I think a lot of our general population stuff comes, when people decide to do things that they are not quite used for. Classic one at this time of year, people deciding to go out and do an absolute load of gardening. You know, it's just, they're generally fit and healthy, but they're going to be sat in the garden, digging things up, pulling out weeds, painting fences for hours on end. And they don't have the strength to meet the demands of the task at hand. Okay, moving on. So what I'm going to move on to now is some ideas from the literature about how we should phase rehabilitation plans. So this one was written by a guy called Brian English a few years ago now. This was taught on my master's degree. And I've put this in because I think the elements of it are good. I personally have some critiques of it. And when I go through it here, so I want to kind of open it up to the room. So I want some kind of interaction on this bit about what your thoughts are on this bit. So these are what he says, how you should structure a rehab plan. Bear in mind, this guy is very, very knowledgeable, far more knowledgeable than me, and I'm critiquing his work. So first instance, decrease pain and swelling. Number 2, achieve full range of movement and flexibility. And then once you've got that, you move on to achieving full power and endurance. Once you have achieved that, move on to proprioception and coordination. Once coordination and proprioception have been achieved, start to move on to your agility skill. So if you're in a football situation, start to be running drills, ball skills. Once you can do that, return to full training with prevention. So that's kind of minimizing the contact, that kind of thing, before we return to play and full training. Okay, now I want people to unmute mics a moment. So what do you think? Is there anything with that you've got comments on?
I think it's okay to have that idea, but trying to stop someone might be quite hard, I think.
In regards to?
Actually saying, you know, before they can return to full training with prevention.
Yep.
If I make them try and stand on one leg and do the vestibular system, I'm not sure that would happen.
Yep.
In a real world situation.
It kind of gets this kind of gets addressed in the next few slides when I kind of move on to the other theories. But my kind of I think all of this needs achieving before we get to 6 and 7. But my kind of thought process is, why is proprioception and coordination number 4? How do you distinguish between these? So achieve full range of movement and flexibility, fine. That's fine at the beginning. But you don't want to be doing power stuff before you've got actual control of the joint through a full range. How easy do you think it is to solely concentrate on power and endurance with no proprioception and coordination, or agility and skill? Because in my opinion, a power exercise is a proprioception exercise as well, because you need to have balance, you need to have control, you need to be coordinated. So I understand the elements behind the individual sides of it, but I think it's quite, if you were to just work through that bit and go, right, we're not doing any proprioception before we do full power and endurance, I think it kind of opens you up a little bit to problems going forward. Because if you're doing endurance, that endurance may involve jogging, walking. You know, if it's a tennis player, you know, it may involve, you know, more shoulder work. When we talk about proprioception, everybody kind of just thinks of it as balancing on one leg. Proprioception is about where your perception and your control of the joint through space. If you can't achieve, if you don't know where your limbs are, do you want to be putting a barbell above your head? That's my kind of, that would be my kind of thoughts behind it. And I think it'd be quite difficult to break this down into 7 categories like that. So we kind of discussed this at length when I was at university, and a lot of people had the same sort of ideas. Since then, I came across this not so long ago. So it was a lit review on phases of rehabilitation. And these kind of went through a lot of different kind of research that is out there within the sporting world. And they kind of broke it down into 4 sections. So they generally have 4 sections. You'll notice the 1 and 2 are pretty much exactly the same as that one. So reducing pain, increasing flexibility. Number 4 is exactly the same as number 7. So phase 3, returning and increasing strength, endurance, agility, balance, and proprioception. That's all one phase because I think it works hand in hand. If you want to look more into that, the references on screen there. So it's Lucky Angiat, I probably murdered that name, and it's sports rehabilitation phases. So it came out last year, was it? Yeah, last year. This is one I've seen quite a bit on social media. This is part of the Physio Network. I've seen it on their social media stuff. And I think this links quite nicely to this one, 4 phases. However, I think it gives a lot more of a structured process. So once again, it's a 4-phase rehabilitation structure. And these are very good for, you can kind of make a little sheet and kind of go, right, phase 1, what's my focuses? It gives joint focus, neurological focus, strength focus, and movement focus. So rather than just going back to this and going, we are going to increase strength, endurance, agility, balance, and proprioception, this gives you a little bit more of a framework to work with. So if we look at phase 1, regain passive range of motion and active range of motion, that is the first priority. So it's obviously missed out the decrease in pain bit, but if we regain full range of motion, I would imagine pain and swelling is pretty low by that point, or better than what it was initially post-injury. The neurological focus, graded motor output. So how much can you get the muscles to activate, basically. Strength focus. So it's not high resistance stuff, it's just voluntary muscle activation. So it could literally just be a static and isometric contraction. Movement focus would be controlled and predictable. So if we take somebody with an ankle injury, and they are 3 days post-injury, they're in phase 1, we're not going to get them doing hopping, change of direction, anything like that. Everything we get them to do will be controlled and predictable. I'd even say walking, if it's a bad ankle injury, could potentially be unpredictable, because as they plant their foot, they could lose balance, there could be something on the floor could be they need complete control of that situation to avoid further injury. Phase 2, loading through full active range of motion. So in phase 1, when we're doing the voluntary muscle activation and the graded motor output, it's probably mid-range isometric stuff. As we move into phase 2, it's probably more of a loading through a full range. How much load? That's what we'll discuss later on. In fact, I don't think we discuss it in this one. I think it's in part 2, because when I was writing this, it started getting very long. Neurological focus, so proprioception and stability control. Strength focus, this is where we start to move into the hypertrophy, actually building muscle back up from post-injury. Movement focus, so external stimuli and organized. So this is where you can start to add in other stimulus. So if we're doing an ankle injury, let's say, we can have them standing there, we can get them catching a ball, but in a static way, and it could be left, right, left, right? They know what's coming, but it's going to give them an external stimulus that they have to focus on. Even get them, right, if we're doing movement focus, right, going to go to use a clock face. Going to go to 1, back, 2, back. These kind of things. So they're in control of it still, but it's just stressing the movement outside of that controlled element. Phase 3, end range strength, optimization of range of motion. Neurological focus, reactive elasticity. So this is where we start to move on to kind of more plyometric stuff. Strength focus, strength, speed, reduced fatigability, endurance, I would say, and movement focus, increasing complexity and effort. This is probably where you're starting to move into more training kind of side. So if we go back to a sporting environment, this is where they're going to start to do probably game drills. I wouldn't say kind of contact, return to play stuff, but this is where it's a little bit more sport specific, activity specific. And phase 4, which is obviously our last phase before we go, right, go away, get back to full training, is maintaining end range of motion. So we don't want to lose any of this. So, and the important part about all of this, if you lose any of these throughout, if you can't achieve one of these things, we move backwards. So we always have to hit criteria for that phase. You can't hit the criteria for that phase, move back and start again. When we go back to phase 1, if you're getting pain and swelling, if you're getting really bad swelling with any, we have to move back. We have to regress because it has to be safe and effective. Neurological focus on phase 4, maximal recruitment. So we're looking for that muscle working, as many motor units, many fibers working as possible. Strength focus is on speed, strength, endurance, and power. So this is high level stuff, what they need. On the movement focus, it's the agility, it's the kind of darting in and out, it's the sport specific. This is game unpredictability. There's a paper, which I believe is next. Anybody here come across the control chaos continuum? No. Okay, so this is a really good thing. So this, it's aimed at football, but it's very kind. I completely get the graphic on screen is impossible to read. I am up close and I can't read it. I've got another slide in a minute which breaks it down. I'll give a kind of quick overview on this bit though. So once again, the reference is on screen. So it's Tabner et al. Progressing rehab after injury. So the idea behind the controlled chaos continuum is in the early stage, which is green. So this is when, so what you can't see on it, it's return to running, basically. So it's when you kind of get to that point when you get a person back running. Excuse me. So the high control part is that initial stage. So we're kind of going towards probably phase 3-ish, depending on the severity of the injury. It's straight line, it's controlled, there's nothing else going on. It's controlled pace, set pace, at a set volume without aggravating the injury. The control to chaos bit, so that is controlled. Chaos is a game situation which has high unpredictability and is high end with regards to strength, power, agility, speed, that kind of thing. And the moderate control and moderate chaos are the bits in between. Like I said, it's really hard to kind of read on screen. Or a little bit here. So high control. And the good thing about this is it gives you a really good evidence-based kind of framework to go, right, what is it I need? If I'm doing running with people, if I'm doing getting somebody back to football, what is it I need to do at each point? It gives you a really good framework to work to. So if you look at high control, so gradual increase of volume at lower speeds. So this is below 60% speed and it's gradual. So if they're coming, so once again, this is football focus. So This will be aimed at knee injuries, hip, ankle, that kind of thing. Minimized acceleration, deceleration. So the reason for that is because an acceleration is a maximal power, and a deceleration tends to be more eccentric control, which takes a lot of force to actually control. One thing I kind of really believe in when in rehab is deceleration training, adding in a lot of deceleration elements into the later stages, because that's the thing that kind of gets missed. Everybody wants to run really fast, but people can't stop. So those can be quite high risk when you first get back if you haven't got the control. At this point, minimized sport-specific stuff. So it's probably just passing, it's probably just running, controllable, that kind of thing. As moderate control, so we've got no chaos just yet, we increase the explosive distance. So we start to add in elements of the acceleration. We increase the speed up to kind of 70%. Increase change of direction. So in phase 1, everything is controlled, straight line. As we get to number 2, gradual changes of direction. One thing I always do is kind of like go to a cone and you can loop around it. So not there, because that is a sudden movement. It's a little bit out of control. So I like to make it nice and gradual. I don't get them turning back on themselves like stop start, because that's a deceleration, which at this present moment, I don't want to particularly do. So it's about gradual changes of direction in a controlled manner. Okay. As it mentions there, with, without ball, depends on what the sport is, depends on what your goals are for that person. If at this point, you don't want them working with a ball, but you want to work on that change of direction, fine, we can build that in as we go along. So this is where the control, the chaos bit starts to come in. So speeds vary. So it's now a little bit more varied. So there's a little bit more chaos entering the scene. We are starting to work different energy systems. So anaerobic, aerobic systems start to target kind of explosive power a little bit more, that kind of thing. So it's getting a little bit more reactive to what's in front of you. So I'm not going to kind of go, right, what we're going to do is we're going to run to that blue cone and we're going to turn off into that direction. It's now starting to become a little bit more reactive. Right, I'm going to go to here, and when you get to here, we're going to give you a cue to turn left, right. We're going to get you a cue to change speed. We're going to throw a ball at you, that kind of thing. So we start to add in unpredictable elements. That's the chaos side of it. As we move on to moderate chaos, so it's high speed, increase under both control and chaotic situations. So it's higher speed, and it's going to be more game situation. As you can see there, it says extensive football. So more ball work, more kind of sport specific drills. So we're now going to start to be doing sprint drills, acceleration, deceleration kind of thing. So they're going to start to be getting towards the top end. We're going to start to include more game situations. So controlled small game situation if we stick with football. And when we get to the high chaos, that is free for all training. So when you're out training, rugby, football, basketball, whatever, tennis is exactly, anything that is a sport where you are competing against somebody, that will have an element of chaos. If we take the tennis situation, so we can kind of relate it to a different sport, you don't know where that ball is going to go. You don't know how fast it's going to go. You don't know how you're going to have to react. You don't know where you're going to have to be on that court, how hard you're going to have to hit, what swing. That is a chaotic situation in that sense. Does that make sense to everybody? Okay. If you need me to stop, just say. Okay, so start to get on to adhering to plans, because we all know spend ages doing plans for people and they don't do. And I've always said the best rehab plan is the one that actually gets done. is that nobody's going to get better by not doing one. Rest is not rehab. Okay. Looking through research, is kind of, so this is another systematic review paper, so it's kind of brought in a lot of research from other papers. So it suggests that adherence and rehabilitation is influenced by two main categories, and that is personal and situational. For the person situation, this goes back to what we were saying at the very, very beginning about what the external influences are, what may actually hinder those people. So the injury, they may be really down about the injury, motivation to actually rehab and complete this plan. Confidence, if they've had a really bad knee injury and you're going to start asking them twisting and turning, their confidence may not be there. It's about how you build that up. If you're going to give them drills that they do not want to do because they think they're going to re-injure, this is where we need to kind of start to play this in. We need to regress. We need to start doing things like this. How they cope with their injury, their support network. Do they have friends and family to kind of help them with this kind of thing and motivate them? An appraisal, that comes from you, basically. If you're part of a coaching team, a multidisciplinary clinic, it comes from you as a collective. This is your job, basically. You give them the feedback, keep them motivated. And then situational, the rehab strategy. If they do not buy into that rehab strategy, if you don't convince them that if that strategy is just not right for them, they are not going to adhere to that. The therapist, if they don't have a connection and don't have a belief in that therapist, they're probably not going to be as motivated to do treatment, especially if you're giving them to do it away from clinic setting. And the treatment efficacy. So is it working? If they don't see progress, are they going to continue? And remember, no matter how much you plan, there would always be things that throw you off course. It never, ever goes to plan. I had this exact situation today. Like, right, we're ready to move on with this girl I was seeing with a knee injury. I planned the rehab out, came in, and she was in a lot of pain and had less movement than what I expected. So the plan I had was just not applicable. So I had to completely redesign the plan when she came in. But that's normal. We see that all the time. In a sporting situation, in a normal clinic situation, the amount of times I've planned a session and they come in and go, I can't bend over, my back's hurting. I'm not going to get them doing the deadlift, the high level deadlifts that I wanted them doing if they can't bend over. So we have to regress. But it's how you as a therapist react to those hurdles and overcome and put something else in place. This is why with rehab exercises, I have some go-tos. I'm like, right, if it's a back injury, I have these go-to exercises. So I don't have to stand there and go, right, what am I going to do with this person? I already have a bank of ideas in the back of my mind that I can do with this person safely in a situation. Okay, how are we going to start measuring our kind of progress? And I think this is one of the things that often gets overlooked. So baseline measures, and these baseline measures can be a lot of things. So if we take a sporting situation, your end goal is to get that player back playing their sport. That's your job. If it's a client in your clinic, that end goal is going to look very, very different. Like I said before, it might be, I need to go shopping. I need to pick up my grandkids. I need to just go to work. So your baseline measures and how you measure these are going to be very different depending on the population and the person in front of you. So I've called it return to play. So RTP, return to play. It's deciding when an athlete may safely return to full training or play once they have fully restored their strength, power, speed, agility, quickness, endurance to match the demands of the competitive game. That goes back to the phases of rehab that we talked about before. So we need the strength, we need the power, we need the speed, agility, all that kind of stuff. What baseline measures you use massively depends on you as a therapist, your experience, the experience of the athlete, the time you have available, equipment and facilities. And I think that's one of the things that kind of gets overlooked a little bit. Time is a massive one. You don't want to kind of go, right, I've got all these battery of tests. If it's going to take an hour and a half, well, you've only got 30 minutes to do it. There's no point in doing it because you just won't get it done. And it must be relevant and repeatable. A baseline measure is to monitor your or the athlete's progress or your client's progress. There's no point in doing something if you are going to get a different result every time you do it. So it needs to be relevant to that person in front of you and repeatable. What kind of things? So I'll put some quite easy-ish things that everybody can kind of do. So you can kind of, some of this is subjective, some of it's objective. Pain. You know, most people come to us because they're in pain or discomfort. How can you monitor that? Visual analog scale, different kind of measures along to that. The efficacy of that is obviously debatable, but I still think it's needed. Edema, swelling, inflammation. If this is a knee injury, can you see the swelling? Does it feel hot? You know, these are things you can look, these are clinical things that you don't need anything else for. You can measure. So you can take a bony landmark above, below patella, across tibial tuberosity, use a tape measure, compare it to the contralateral limb. How much swelling's there? You measure it on day one, get them to do their rehab stuff, decrease in pain and swelling. You measure it again on the next visit. That is an objective measure that you can monitor. And it gives you a good baseline measure, and you can test it against the contralateral limb. And it gives you a good idea of how much swelling will be there. And also moving forward, when you're doing things, if you're not quite sure if an exercise is right for that person, or they've had a negative reaction, and you think it may have caused a response where it has swollen, you can actually retest and you can measure. Active range of motion, easy as pie. Well, just been using one. So I've got a few things I do active range of motion with. I've got a goniometer, which the big clear goniometers. I've got I don't use this, it's far too faffy. I've got a little handheld dynamometer, which links to my phone. I don't use that for range of motion. I use it for strength stuff. But I found one of these on Amazon. So what it is, it's actually made for joiners, I think. It's got a little digital display. And you click on that, and as you move it through, it tells you what the angle is. You can move it to any point, zero it, and you can check quite accurately what range of motion is available at several joints. Passive range of motion. How much? How does it feel? Do they have an end feel? So does it feel the same as the good limb? Does it have a, every joint has its own end feel. Is it a hard end feel? Is it a soft end feel? If it's soft and spongy where it's normally hard, that's not a normal end feel. You can make a note of that. You can monitor that going forward. Strength. How did you test strength? Was this literally just putting your hand on and go and push against me? Yeah, that's about right. That's not a very objective measure. There's loads of ways you can do it objectively, or as objective as possible. Like I say, I use this, which is an active force dynamometer. They are quite pricey, but I do use it a lot. You can also get crane scales for people who've seen those. I've got one right here. So I think these were made for construction and weighing fish, I think. So this one's measured up to 300 kilos. So you can do a mid-thigh pull, a squat kind of thing, and pull it apart. Obviously you can't push, but you can do knee extension. You just have to tie something around here, and you have to anchor it to something immovable. But you can get a good kind of baseline measure. This one's quite a big one. So if I was doing knees and shoulders, it probably weighs a good kilo and a bit itself. So bear that in mind. You can get smaller ones. Other things I've used kind of get through luggage scales. The cheap luggage scale. Be aware that sometimes the clips on them are a little bit weak, but you can get a measurement. If you get a digital one, it tells you in front of you how much it is. And a lot of them will go up to 50 kilos, which for some people, certain populations, that's very applicable. You know, dead easy to, it works in a similar sort of way as that. Just band around one side, ankle, if you're testing dorsiflexion or something like that, you can hold it in one place, pull against it as hard as you can, and you get a measurement. So there's loads of ways you can do that quickly, cheaply, easily. You don't need force plates. You don't need all these speed gates and high-end dynamometers. There's loads of things you can do. Next on the list, functional movements for activities. So, you know, you don't need anything. So the star excursion balance test, the upper limb star excursion balance test or Y balance test, those kind of things. You know, there's loads and loads of different functional tests for shoulder injuries, knee injuries, all these kind of things in the literature that you can kind of pick up. I quite like using the star excursion balance test because it's super quick and it gives a good kind of measure of how much movement and control they have over a single limb. So those are some of the baseline things you can use in clinic. If we're kind of starting to measure return to sport stuff, this is where you have to kind of start thinking about, right, what is the sport? What's the demands of the sport? What is it they need to be able to do? Because return to play for a footballer is going to look very different to return to play for a basketball player. You know, similar kind of movements, but it's very different. One uses a lot of upper body, one uses a lot of lower body. Very, very similar, but it's going to be different. Different surfaces, different kind of distances, different skills needed, more explosive jumping in basketball. I'm not saying you don't use that in football, but it's obviously very different. So you need to start thinking about those kind of things. What does that person need for that sport? And the plan that you're putting together not only should be kind of based around what your end game testing procedures are, but also what the needs of the sport are. As well as that, have a look if there's any deficits that may be present elsewhere. So it may be that they come to you with a knee injury on the right-hand side, but for the last 6 months, they've been struggling with their left hip, or their endurance or their shoulder is a little bit, you know, they've been having an irritable shoulder. This is a good chance for you to add in these other elements. So don't just focus on the knee injury. We're going to do loads of knee focused stuff. I'm just going to mute that. Does that make sense to everybody? Okay, so when we are testing, the training part is testing. Testing is training. So as you are going through the testing, it's a lot of the testing is quite high demand, you know, because you're trying to test them to their capability. That is a training session in itself a lot of the times. And when you're actually training with them, you are testing them, because if you're doing agility stuff, you are testing what their agility is. So it all works as one big continuous program. It's not, we're doing a testing session, doing that. If you're measuring, yeah, fine. That's, you know, if you're taking figures, but it's a continuous program. Okay, so we're going to start moving on to exercise selection. So these need to be specific for the needs of that person in front of you. So there's no point in kind of going, right, we're going to do a load of deadlifts, a load of 3RM deadlifts, if this person's an 80-year-old woman who doesn't need that kind of thing. You know, don't get me wrong, I'm not saying 3 rep max deadlift is not going to be a benefit to an 80-year-old lady, but is it specific to them? Is that what they need? Or do they just need some general exercise? What are the goals of your phase? So this is where we go back to however you decide to structure, whether it's your 7 phase, your 4 phase with your individual breakdowns. Break down your criteria, what it is that you need to move on to the next stage. Sin factor, so your severity, irritability, and nature. Always think back to that, because if they start to get a negative response with some of the plan that you're doing, some of the exercises that you're doing, you need to be able to kind of think about how to regress that or change it. So the exercises that you give them to do should be aimed at not increasing symptoms. Okay, so it's about pushing it to the brink without pushing them over the brink. And like I mentioned just previously, think of the physical aims and demands outside of the injury. If you've got a high-level sports person, and this goes for recreational runners, if that recreational runner has an ankle injury and can't run, they still need to keep their fitness levels up and their cardiovascular and their endurance. They still have a good leg. You still need to consider that. So you still need to incorporate elements of that into your plan, because otherwise you're going to work everything on that injured limb and build up the strength, build up the endurance. Meanwhile, the non-injured one is kind of been doing little bits and bobs and probably regressed and gone down a level, whereas you need to maintain that fitness. You maintain overall endurance, strength, and power everywhere else. It makes everything else so much easier. Okay, sticking with exercise selection. So obviously there's a million different types of movements. And depending on the phase that you're in, the kind of injury that you have in front of you, the sport that you're rehabbing towards, will determine what kind of movements you are going to choose as part of your rehab plan. Are you going to be doing single, multi-joint, or compound type movements? So, if it's an elbow injury, are you just doing flexion extension, or do you want to incorporate the wrist and the hand? Do you want to incorporate radial ulnar joint? Do you want to incorporate shoulder? Do you want to incorporate, thoracic? What other things do you want to involve in, rather than just doing flexion and extension? Are the movements you're doing active, passive, or assisted? So it's active, obviously they're doing it. Passive, you can do it or they can do it. So if we move to elbow, stick with that. They can hold on to for a broom or something like that, or literally just move it through themselves. That's a passive movement. Okay, so in the early stages of an injury, if you're trying to reduce stiffness, pain, that kind of thing, passive movement may be really, really beneficial for them. Or is it an assisted? So same with that. They're going to move that limb, but you're going to just give it that little bit of a helping hand on the way. So it's kind of, they're doing, 50% of the movement with the injured arm. And the other 50% is coming from them actually moving it. Do you need to address any other limb or joint dysfunction or weakness? Is this injury resultant of, so yes, fair enough, they now have an injury in their knee, in their ankle, in their hip, wherever. Is that resultant of an overload injury at that site, or is it due to movements from elsewhere causing an overload in that situation? If it's on their right knee, is it because their right hip is lacking in flexion, extension, abduction, rotation, which is causing an increased load on the knee when they're running and changing direction, that kind of thing. So look outside of the actual injury site, above, below, all around, other limb. Is there something else in the chain somewhere that needs addressing? Because that should form part of your plan. What plane of movement are you going to be working in? So sagittal, transverse, frontal. So transverse is more rotational stuff. I had a conversation with somebody the other day. I think rotation gets neglected in certain elements, but it's quite difficult to work in just one plane in a sport setting as you get to the higher end. But in the lower end of stuff, you can just work in one singular plane. Is it open kinetic chain or closed kinetic chain? So if it's a knee injury again, is it an open kinetic chain? So are you doing knee extension, so the foot isn't fixed? Or are you doing a squat, so the foot is fixed to the floor? So an open kinetic chain, something where the limb can move around in space. Closed kinetic chain, foot planted on the floor, you've got a grounding, so closed. And once again, go back to the maintain and fitness for sport. Types of contraction. So super simple bits for this. Everyone will be aware of these kind of things. So concentric, isometric, and eccentric. So what stage that person is at, what type of injury it is, and what your goal for that phase is going to probably determine what kind of contractions you want to be doing. So in an early stage muscle tear, you're probably not going to be wanting to do high end eccentric exercise, because it's going to be very demanding on the muscular tissue. Probably needs an element of eccentric exercise, but obviously you need to kind of dose that correctly. So concentric contraction, give a quick overview just for people listening later on. So active contraction and shortening of muscle as tension is produced generates a submaximal force, but requires the greatest amount of energy. So out of those three that we just mentioned, concentric contraction has greatest amount of energy demand. An isometric contraction is an active contraction with no change in length. So this is what we were saying earlier on. So you find a point, is it basically pushing against an immovable object? When I say an immovable object, it's an immovable object for what that person is and however much. It may be putting one hand on top of the other and just pushing in and just resisting. There's no joint change of angle, there's nothing, but you are still recruiting muscle fibers. You're still getting a contraction. With isometric contractions, you can generate a maximal force. If you try to pull against something that is immovable, you are going to create a maximal force. Okay, has lesser energy expenditure than concentric, but produces greater force. Okay, so I quite like using isometric contractions and exercises throughout all stages of rehab, because you can find a nice point and you can build up a lot of strength quite safely. Because the longer you hold it, the more fibers, the more motor units get recruited as the fatigue factor kicks in. And then eccentric, which is the active lengthening of a muscle as the tension is produced. And these can generate greater forces than a concentric, but use less energy than the other two types of contraction. So the force produced can be greater than a concentric and isometric because it's the active lengthening. So if we go to the immovable object, it's letting that down. So, it's walking downstairs. So it's not walking upstairs, tends to be more of, if we take the quads, concentric, so because of the shortening as you lift up. When you come down, you're not just falling downstairs, it's that muscle lengthening out to allow you to make that next step. So it's not your hamstrings actively contracting to bend your knee as you go down the stairs. It's your quads actively extending and releasing out eccentrically to allow you to go down those stairs. Okay, once we've got what type of muscular contractions we want to kind of use in specific exercise, in specific phases, we also need to start to think about the speed of contraction. So if it's a concentric, is it nice and slow? Or is it a sustained isometric? Is it a quick or is it a slow controlled eccentric? How long is that going to last for? So if you're taking an isometric, for instance, how long are you going to hold that isometric contraction for? If it's an eccentric lowering exercise, so we'll take, eccentric loading of the calf complex and the soleus for Achilles tendinopathy. That's quite a commonly used thing. How long is that contraction going to be over? And we call that time under tension. So how much time is that muscle and that tendon and that joint under tension for? And then we get onto the acceleration and deceleration bit. So acceleration bit it's a maximal power kind of thing. So it's explosive. The deceleration bit, so if you're running a straight line and you suddenly want to stop, it's obviously a full body thing, but what is kind of helping slow you down is the eccentric contraction of soleus, your hamstrings, and your quads, because they're slowly allowing you to stop. They're not just contracting to allow you to stop, they're controlling you through and allowing the joint to slow down. So that is quite a demanding activity. So deceleration is quite a demanding task. Let me cursor go. Okay. One of the things that I think gets overlooked, and we've discussed this on other chats and other things, is if we're in a clinical setting and we've got Joe Public who has come to see you for a shoulder injury or a back injury, anything like that, when you are designing that rehab program or you're going to give them exercises, what is applicable to them outside of the clinical setting may be completely different to what is applicable in a clinical setting with regards to what do they have access to. And I think this is one thing that gets overlooked quite a bit. So obviously in high level sport, they've got access to everything. They've got running tracks and gyms and force plates and everything. If Gary, who works in a factory down the road from me, comes to me because he's hurt his shoulder, I go, right, I want you lifting 20 kilos above your head with a dumbbell, but he doesn't have a 20 kilo dumbbell, then it's not applicable. And I've put on here, there's no point in prescribing 3 rep max deadlifts if they don't own a barbell or have access to a gym. So yes, that may be a great exercise, but if they do not have that equipment to hand, there's no point in prescribing it because there's just no way of doing it. So this is where, as therapists, we need to start being a little bit more kind of novel in our ways of thinking, problem solving. And I really enjoy this part of it because the amount over lockdown, I haven't got anything. But you've got lots of stuff. You have absolutely loads of stuff in the house. No, I don't. So I put on screen 3 different variations of a deadlift. So the first one, yeah, fair enough, the different stances, and it actually winds me up a little bit that the first one's a sumo deadlift and the other ones aren't. But the first one, it's obviously a barbell with Olympic plates, and they're doing a deadlift. The picture in the middle is still a deadlift hip hinge movement, but it's using a resistance band. So probably with that resistance band there, you're not going to get the high level resistance that you're going to get with a barbell and Olympic weights. If you use a heavy resistance band, if anybody's used one, you can get a lot of resistance, but it reacts differently to a weight. And also pulling up against your feet reacts very, very differently to how you would with that. But if they haven't got a resistance band, what are you going to do? And the third one is an isometric mid-stance hold using a towel. Everybody's got, well, I would like to think everybody's got a towel. I'm not even going to comment. So everybody should have a towel, belts, a leather belt or a strap, anything like that. Something that doesn't have much give to it. You can get really, really creative with things like that. So if we use that deadlift situation, yes, fair enough. That's an isometric contraction in probably it's probably the lower end of the phase. Do it throughout. So we do a 10-second hold at that point, and then we move up a few degrees, so we're a little bit straighter up. and then we do a 10-second hold at that. And then we move to the end range and we do a 10-second hold of that. And you work through the range. So you can start at the very, very bottom, do an isometric hold that for however long you feel necessary. They are in control of that exercise then. This is quite good for people who have lower back pain, knee pain, hip pain, who probably are lacking a little bit of confidence and don't think they can lift weights, because that can be quite a daunting thing. You can use this as a confidence builder. You know, I've used that crane scale, kind of go, look, I've wrapped it, it's a really rudimentary platform. It's just a plastic chopping board that you put a strap around, hook the crane scale to, hook the bar to, and you pull up and it gives you a reading. It's an isometric contraction, the same as what the towel one is. If I'm telling them I want to deadlift 50 kilos and they're telling me they can't, but when they pull on that crane scale, they're lifting 60, I'm showing them they can lift more than what I'm asking them to. And going back to the isometric one here, they can complete control of it. Same with the resistance band. If anything goes wrong with that, the worst case scenario is you leave go and the band hits the floor. With the weight at the early stages, if they're in pain and they're on their own and they drop it, they may cause further injury. So it's about these other considerations outside of that. Safe and effective. Anybody, any questions on any of that? Any comments? Nope.
Can I just ask, Scott?
Yep.
When someone comes into you and about this rehab, do you sort of like consider everything and then make a plan for when they come back again, or is it something that you have a plan?
It absolutely depends. Complete cop-out answer. So in the first couple of sessions, I discussed like how I kind of structure my initial consultation, because I like them to go away with something, whether that's hands-on treatment or some exercise or whatever. So I like to put in more time in the diary for that exact situation. And I like them to go away with some exercise, and that's go back to, I have a bank of exercises for different joints and different things that I can call upon, that if I need to come up with something on the spot and go, right, there you go, here's some stuff.
Okay.
But I actually use the exercise side, like I said earlier on in this presentation, as part of the testing process. So if I want somebody, I'll go back to one I did today. So lacking hip extension, we've got lower back pain. I want them to do a glute bridge. I want them to, ideally, what I want them to do is a single leg glute bridge on a step. That's not the first thing I do with them. So I kind of take them through. So, right, 2 legs on the floor, right, lift up and hold. Right, can you do that? Okay, fine. Right, move your good leg slightly further out. So you're taking most of the weight on your injured side. Okay, you can do that. Right, lift up to the top, lift one leg in the air. When you're at the top, hold that and lower down on one leg. So these are all incremental progressions that you can use. If they can do that, right, let's go on to the step, and we use that same protocol. And so 2 legs, lift up, right, fine. Okay, lift up, lift one leg up. So it's about progressing it, progressing it really,
yep. Okay.
in kind of nice little increments, rather than I have an idea of the end goal of what I want to do with them. But that's if this person's quite aggravated with injury and they're in a little bit of discomfort and stuff like that, I am not going to start with that exercise if I don't, because I want to kind of build up there. So if I get them to do that first and they go, ow, that really hurts, I've just lost their confidence immediately because I've just caused them pain. So it's about building up with this stuff. And it's one of the reasons why I quite like using isometric stuff, because they're in complete control of it. And I use it for shoulder injuries. So we can hold the shoulder into this, you know, kind of push down, right, hold that, and then move it into various ranges. You know, you can get them resisting abduction and internal rotation at the same time. So you're kind of getting a bit more of a shoulder activation, stability kind of exercise. but they're in complete control. And literally when I do that initial kind of stuff, I'll just use 1 or 2 fingers, so it doesn't feel like I'm pushing down on them. But that kind of stuff I can incorporate into a rehab plan for them. It may not be the conventional, right, let's lift weights, let's use resistance plan. For an exercise with progressive overload is the same thing. But going back to your question, I have these things in my head that I can use. If I think, right, it needs more of a specific plan, I go, right, what we're going to do is we'll sit down, here's your exercise for this, see how you get on with these initial bits of exercises to deload and kind of de-stress and kind of get used to the movement kind of side of it. I'm going to send you some stuff to do, and I'll send an initial plan over, and then when they come back, and then we discuss and go through more aims and we progress it that way. When I'm working in rugby, it's very different. I've pretty much worked like we're discussing now. Right, that's where I want them, that's where they're at. I have more contact time with them. So I kind of, right, on a Tuesday, this is what we're going to do. Right, let's see you on Thursday. Let's see how you progressed. Right, I can see you on Saturday morning, pre-game. If you're not playing, right, I can see you then. So I've got more contact time. Obviously, in this kind of setting, I probably don't see people 3 times a week. Is, you know, financial restraints. People don't have the ability to do that. This is where we need to kind of be realistic with what we give them to do outside of here. Because if I've got equipment that they don't, there's no point in me going, right, well, I want you doing this exercise. I've got a cable pulley system. They probably don't. So there's no point in me giving them those kind of things. So it's about building up these kind of bank of ideas in your head that you can send people away with while you do the further planning.
Okay. Thank you.
Does that make sense?
Thank you.
Okay, so we move on to the dosage kind of side of it. So as we've kind of discussed, you need adequate stimulus and overload for the adaptations to occur, but without aggravating the injury. And I go back to the previous example I used. There's no point in giving 3 sets of 10 reps of yellow TheraBand knee extension if they can do that with absolute ease, because that is not causing an overload for adaptations to happen. So when you're doing this kind of plan, and this is going back to what you've just discussed there, Helen, how many exercises are you going to do? How many sets and reps? How many days? I'll take those ones for the time being. That is very, very dependent on who that person is, what their background is, what they have access to. So am I going to go, right, here's 10 exercises to do 4 times a week in a gym setting if they don't have access to a gym, but I want them or want them to come here? It needs to be realistic for that person as well. And this is where we kind of need to be a little bit careful about discussing the rehab side of it, because a lot of it we kind of, and I've been guilty of it in this, we're talking about sports people. A lot of people we treat are not sports people. They're just general public who need to fit this into their general daily life. So how many exercises are we going to give them? With those exercises, how many sets and reps are we going to give them to do? How many days are we going to get them to do these exercises? Are you going to give them something to, same exercise to do every day? Or are you going to split it into, right, on 2 days a week, so day 1 and 3, you do these exercises. On day 2 and 4, you do these exercises. On day 5 and 7, do these exercises and you have 1 day rest. That kind of thing. So how you choose to structure it is completely up to you, you know, and you have to have that conversation with the person. How much time are you realistically going to put into this? If I give you 10 exercises, are you going to do them? Probably not. General public are probably not going to go away and do that kind of thing. They need something short, sharp, that they can fit into their daily life, you know, and it's about, it doesn't have to be, right, here's a 20-minute plan to do. Somebody's got an ankle injury, get them doing calf raises while they're brushing their teeth. Go, you know, so I get people doing squat, right, how many times a day do you have a cup of tea? I have about 5, 6 cups of tea a day. Right, every time you boil a kettle, stick the kettle on, and I want you to do squats until that kettle boils. When you're doing the washing up, I want you to stand on one leg. This is all part of rehab. It doesn't have to be all in one go. It's about, sometimes for some people in certain situations, about little and often, and fitting it in around that situation. I have a lady who comes to see me. She was a librarian, and I gave her those kind of things too. You know, she used to make cups of tea for people. I was like, right, when you're washing up, I want you to stand on one leg, and I want you to move your leg out there, and that, so it gets your balance element going. And I was like, you're going to look crazy at work, but trust me, it's fitting in. And then all of a sudden, everybody's doing the squats while the kettle's boiling. You know, and like while they're washing up, people are doing balance exercises. When they're behind the counter, they're doing calf raises. You know, so it kind of rubs off on everybody else. So it's about problem solving around what is in front of you. And that's where I go back to the very, very start about the subjective assessment about what is right for that person. Because this is all about clinically reasoning the exercise you give them. Okay, so we've gone on to how many days. How intense or difficult do you want that exercise to be? That will depend on the stage of the injury, the adaptations you actually want to occur, and how much is acceptable with regards to discomfort and pain. So everyone's probably seen this kind of thing. So yes, you need adequate stimulus and overload for things to happen. However, if they have a significant pain response, sometimes that pain response will be due to the overload being too much. You know, it's for a reason. If that pain response results in the joint swelling or the limb swelling, it's because it's too much. So we can use the pain scale as an idea of optimal kind of levels. This is not always applicable to people. Like, so once again, I'm going to use an example from today. I couldn't have worked in 0 to 3 on a pain scale exercise level with a client today because her baseline pain level on her leg when she came to see me today was a 5. So that immediately kind of goes, right, so what do we do with this person? We don't want them going into 6 and above when we're doing exercise, but they're sat in front of me at a 5. What do we do with this person? So this is where it's about adapting the exercises, finding things they can do. And this is the one where I kind of went, right, I've got a plan. I've got loads of ideas of what we're going to, can't do any of that. You know, so you have to think on your feet. And there's loads of different ways of kind of modifying an exercise. There's some examples on here. So this is a really good graphic. Who was it? Dr. Caleb Burgess. So I got this off Instagram. Some really good stuff on pages like that one. You know, changing the range of motion, changing the contraction type, body position. The body position is quite, if it's a knee injury and you're getting them doing flexion extension, they can't do it. Get them lying on their side, take gravity out of the situation. You know, if they've, you know, get them sliding it along the floor. So they're still doing flexion extension, but gravity is taken out of the equation. Increase rest time, decrease the frequency, the duration, weight, load, so the resistance of it, how quickly they do that exercise. You know, you might find as you're kind of going through these exercises, this increases, so you need to modify it several times through, or you might kind of go, actually, no, they're quite low. We can probably push you a little bit further, so it works the other way as well. Okay, so sets and reps. So depending on what your aims of the plan are, or the aims of your exercise, whether it's strength, power, hypertrophy, or endurance, there's optimal kind of sets and reps for this situation. So this is a graphic which is kind of been widely used in literature. This one I think was taken from, it's Human Kinetics on this one. So strength range, so basically the yellow is the most optimal. Green in this situation on this graphic is the least optimal. So the bolder the text on the screen, the more optimal rep range. So for strength, we're kind of up to 5-6 reps. So, and that's maximum. So 5 to 6 reps max. Okay. As we start to work across, yes, you are still going to get strength gains in kind of the 7 to 12 range, but it's not going to be as optimal for pure strength as 0 to 6. Power. So this, again, this is the lower end of the scale. So if you want pure power, pure muscular power, it's about lifting heavy weight quickly, basically, over short, it's maximal weight. So that is, again, in your lower repetition. If you're wanting to build muscle, and for instance, you may want this post-surgery, somebody may have come to you post-ACL reconstruction, you want to, yes, you want to rebuild their strength, but you also want to build the muscle mass. So this is where you start to work in different rep ranges, because the aims of your exercise, the exercise may be exactly the same, but the repetition and load will be different. So this is where you need to consider what the aims of your phase and your exercise are. So this is about hypertrophy. So it's kind of generally between 6 and 12 reps. I normally work between kind of 8 to 12 reps. Once again, that's maximum repetitions. By the time they get to that last repetition, it's hard and they can't do any more. Muscular endurance. Endurance is obviously how long you can go for. So this is the higher end of the scale. So up to kind of 20 reps plus. Are you going to be doing these for a long, long period of time? So lower load, higher repetitions for muscular endurance. Okay, last little bit of today's session. Good job I did cut out the other one, the rest of it, because this would have been about 50 years long, I think. Obviously, we kind of want to know, it's all well and good me going back to this and go, right, we want to train you for strength, and we're going to go, right, we're going to lift 6 repetitions of this. And if I haven't done my testing, I don't know how strong that person is, and I go, right, lift 6 repetitions of this, and they do. Okay, how hard was that? Was that actually their 6 rep max, or was it too easy? Can they add more on? So this is, you know, there's loads of ways you can do this. But a super, super simple way is the RPE scale. So I've used the Borg scale previously, but it was a bit too for my personal needs. So the Borg scale is out of 20, and I just thought it was too many increments. I needed something short, sharp, easy. So the RPE scale, if you haven't come across it, is the rating of perceived exertion. So you can literally have this printed out, stick it on a wall, have it there, and you go, right, how difficult was that on a scale of 1 to 10? And as you can see here, 1 to 4 is very light, 5 to 6 is pretty easy. I can do a fair few more reps. So if I go back to that 6 repetition max, and they go, it was a 5, that means they could have done 10 reps at that weight. If I go back to 10 reps at that weight, that's hypertrophy phase, not strength region. So this is where this measuring intensity and how difficult an exercise actually is for the individual in front of you is quite important. Obviously, when we're looking at this kind of thing here on screen with regards to strength, power, hypertrophy, and endurance, we need to take this with a pinch of salt when we're working with an injured athlete with an injured limb, because there's so many other factors that come into it. But as a baseline kind of background and prescription tool, that is quite a good tool to use. And then going back to the RPE scale. So 7 is, I could do a couple more, like 3 more reps. 8, I could do 1 to 2 more reps. 9 is, I could potentially do another rep. And your 10 is, nah, I'm done. Nah, that was too hard. Leave me alone. Don't do it again. So, and that's a really easy, simple way of kind of measuring how difficult all these other bits are. So ignoring the pain bit. So how many exercises, your sets and your reps, you know, so you can go through that exact exercise. If it's too easy for them, it's not going to be overloading enough. So you need to make it as intense as it can be for that person in front of you. Don't get me wrong, you're going to get people who will not want to be up that kind of orange and red end. They'll quite comfortably sit down towards the light yellow and yellow. Yeah, that was quite hard. But you can use your experience of, no, that definitely wasn't hard enough, and just steam all the way up. I've done that with people. I've added weight onto barbells, and yeah, just crack on. And they haven't noticed, and they've lifted it fine, absolutely fine. And then you tell them afterwards, a bit sneaky, but it builds their confidence in a roundabout way. So that is the end of part 1.